Welcome, everyone. I'm Audrey Laporte, Acting Dean of the Dalla School of Public Health, and it's my great pleasure to welcome you to the sixth, can hardly believe it, the sixth annual Vohra Miller Lectures in Critical Public Health Issues, organized jointly by the Institute of Health Emergencies and Pandemics, affectionately known as IHEP, and the Dalla School's Office of Advancement. So thank you to them for organizing this wonderful event. I'm going to start with a land acknowledgement, and I would just ask that you think about the ways that you personally, in your personal life, in your work life, research life, can honor the spirit of the land acknowledgement and the recommendations of the Truth and Reconciliation Commission. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. This meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and live on this land. So I've said it's the sixth year of this lecture series, and this series has really honorable foundations. It was established through the vision and partnership of the Vohra Miller Foundation, and that foundation's mission is to improve the health of people and the planet with a strong focus on equity, evidence-based policy, and community-rooted approaches to public health. Soon after its founding in early 2020, the foundation made a generous $1 million investment to launch the Institute for Pandemics, now IHEP, at the Dalla School. And this gift was key to the creation of the Institute during the onset of COVID-19. Their generosity and vision positions them as one of our school's most impactful philanthropic partners, enabling transformative research, policy impact, and community health initiatives. With a background in clinical pharmacology and toxicology, Sabina Vohra Miller values healthcare but is aware of the systemic racism and structural factors that impact many communities and which leads to inequities in health. And I'll just say on a personal level, as someone who had the privilege of serving on the Ontario Science Table, that I remember the incredible contributions that Sabina made to the effective communication of health information, really at the depths, I'll say, of the pandemic. And so she is truly deeply invested in making sustainable, systemic, meaningful, and intentional changes to healthcare in Canada. And that's why she focuses so much of her effort and advocacy on making healthcare accessible for all, and is such a big believer in community approaches to healthcare, especially by organizations who truly understand the challenges faced by the groups that they serve and with whom they have worked to build trust over decades. So our session today is in keeping with those of the past. It's true to the spirit of this very generous gift made by the Foundation in establishing the Vohra Miller Lectures in Critical Public Health Issues. And so this year, as every year, we bring together preeminent scholars, policymakers, advocates, and community leaders to examine the most urgent and complex issues in public health. Last year, you may recall that we explored culturally aligned AI, and this year we're tackling another easy question. What lies at the heart of our health system? Who gets care when systems are under strain? And how do overlapping forms of oppression like race, disability, and immigrant status shape access to primary care during public health emergencies? So this evening, You will hear from an extraordinary group of leaders whose scholarship, policymaking, community advocacy illuminate these structural barriers that many of our compatriots face when navigating urgent healthcare needs. And their insights go beyond, illuminating issues. They help us reflect on how we build systems that can address these issues, that are truly inclusive, systems capable of supporting the well-being, dignity, and stability of all communities, especially during times of crisis. So our discussion will be moderated by my distinguished colleague, Professor Arjumand Siddiqi, Canada Research Chair in Population Health Equity, whose lifelong work on the social determinants of health continues to shape policy and scholarship across Canada and around the world. So I would like to, on behalf of the school, extend a very warm welcome and thank you to our distinguished panelists. Professor Chavon Niles, Assistant Professor, Department of Physical Therapy, who is a scholar of disability justice, critical pedagogy, and health equity. You'll hear a lot more about each of them and all their accomplishments. The Honorable Kamal Khera, former Member of Parliament and a nationally recognized leader in health equity and public policy. And Liza Arnason, founder and chair of ASHE Community Foundation for Black Canadians with Disabilities. So I want to thank you all for bringing your expertise, your experience, and your dedicated commitment to this important conversation. So I want to thank everyone in the room for being with us and for our distinguished panel and for your engagement in these essential conversations. And so now it's my great pleasure to turn things over to Professor Siddiqi.
Good evening, everyone. It's so nice to be with you. Thanks to Audrey for your very kind comments. I am Arjumand Siddiqi. I'm a professor at the Dalla School of Public Health, and I'm really privileged to be moderating this evening's discussion. Before we get started, I have some housekeeping things to tell you about. So washrooms in this building are located downstairs. The accessible washroom is through the doors at the back of this room and to your right. Emergency exits, there is one behind the stage, one at the front entrance, and one by the ramp, which is at the back of this room, also on the right. There will be a Q&A following the panelists' comments and some initial questions to kind of get us warmed up. So please do be ready with any questions you might have. Our program today will include a roundtable and reflections from our panelists, and then there will be some questions that were submitted in advance, as I mentioned, but we won't be able to get through all the submitted questions so that we have a chance to get through some live ones as well. The event is being recorded and will be posted on IHEP's YouTube pages with closed captions following the event. So I will just briefly introduce our three panelists, and just to give you a sense, and then just make some introductory brief remarks, because we're not here to hear from me, and then hand over the mics to each of them to make some brief introductory comments. So I will start with Dr. Chavon Niles, who is a Guyanese-Canadian researcher, scholar, educator, and advocate dedicated to justice, equity, diversity, and inclusion. She earned her PhD from the Ontario Institute for Studies in Education at the University of Toronto. She is an assistant professor in the Department of Physical Therapy and is cross-appointed in the Rehabilitation Sciences Institute, Temerty Faculty of Medicine, both at University of Toronto. Her research focuses on critical disability studies, health equity, and systemic change, exploring the lived experiences of underserved populations. This includes immigrants with disabilities navigating the healthcare systems, individuals living with long COVID, and their experiences of systemic oppression and inequities in access to care. Welcome. Next is the honorary Kamal Khera, who is a nationally recognized leader in health, equity, and public policy with over a decade of public service. As one of the youngest women ever elected to Parliament, she served in Canada's cabinet as Minister of Health, Minister for Diversity, Inclusion, and Persons with Disabilities, and Minister of Seniors, combining her frontline nursing experience to advance impactful healthcare policy and inclusive systems that empower communities in Canada and around the world. Thanks for being with us. And Liza Arnason. Liza has over 30 years of progressive leadership and teaching experience in the higher education and community sector, including at the University of Toronto. Currently, Liza serves as the volunteer chair of the Ashe Community Foundation for Black Canadians with Disabilities and the University of Calgary Black Alumni Network. Her commitment to equity and the principles of For Us, By Us has consistently anchored her work. Her depth of knowledge and expertise is shaped by lived experience, research, policy development, and extensive professional practice. Liza draws on critical pedagogy, including Black feminism, disability justice, and critical race theory to inform community-based research and policy change initiatives. Through collective leadership across Canada, she continues to design and advocate for new models and systems that drive meaningful and lasting change. Thank you. So let me just make a few comments to kind of get us warmed up to the topic. So we're essentially here to talk about what happens when systems are under strain and who gets care and ostensibly who doesn't. And in my mind, there's many ways to kind of understand this issue. There's a straightforward empirical question. So more or less, you could just sort of account for who's getting care and who isn't. You can speculate about their characteristics and so on, but it's a straight sort of more or less empirical endeavor. There's also a sort of socio-political perspective in terms of the forces that lead to differences in care under strain, and then what the consequences are of those forces. So we can have a system under strain, and we can imagine that people differentially get care, and there's a sort of sociopolitics for how to understand how that happens. There's also certain normative and philosophical questions about who gets care, who should get care when systems are under strain. And then there's the question of troubling or problematizing the notion of a system under strain in the first place. What are the forces creating the strain? Or what's the narrative of strain that's out there? If we can find that, we can likely get to some of these questions about who's getting care and who isn't, because presumably the people who are sort of manifesting the strain aren't the ones that are routinely affected by it. So for me, the question of who gets care when systems are under strain is loaded with empirical and normative perspectives, with socio-political analysis, and so on. So on the one hand, this can seem like a relatively technocratic endeavor to sort of count up who's getting care. We can lament about who's suffering, and we should. But if we turn the lens around, it can also be a question about what has allowed this to occur in the first place, and therefore what the consequences are. So I will now turn the mic over to Dr. Niles.
Thank you. Good evening, everyone. It's so lovely to see all of you in the room. Thank you for joining us on such a cold day. Before I get into talking about who gets care when systems are strained, I always like to locate myself. Thank you for that lovely introduction, and talk a little bit about who I am and how I come to this work, because who I am matters to me just as much as the work that I'm privileged to be able to do. So as Dr. Siddiqi mentioned, I'm a Guyanese Canadian. I'm a biracial settler to Canada. It was not my choice to leave my country and come to Canada, but it is my choice to call Canada my home. I'm also a parent, a caregiver, and someone who has navigated the healthcare system as a service user. I also identify as a temporarily able-bodied woman. I I experience more moments of able-bodiedness than I do moments of disablement. But disability has been part of my life as a caregiver and also as a recipient. My journey actually started as a frontline worker. Before I became a professor and I get to do this amazing work with community, I was on the front lines working with immigrant and refugee youth with disabilities. Eventually, I joined an organization called OCASI, and I always have to honor OCASI because what I'm able to do is through the work that I got to do in community for almost 9 years. OCASI is the Ontario Council of Agencies Serving Immigrants. They act as a collective voice for the immigrant and refugee serving sector. So they have a membership of over 250 organizations. And throughout my PhD, I worked at OCASI, leading a community education program where I trained settlement service providers, educators, and healthcare providers on how to support immigrants and refugees with disabilities. I wrapped up my PhD during the pandemic, actually, and I was no longer working at OCASI, but what we saw is, we were all going through the pandemic, but we were not experiencing the pandemic the same way. And OCASI contacted me because I led an accessibility program there, and they said that as services are moving online, as people don't know how to navigate these services online, and the population, Chavon, that you used to work with, those organizations are really struggling. Can we connect with organizers that are serving immigrants and refugees with disabilities across the country and share back their stories? So that's how the Untold Stories project really came. It was from OCASI connecting with member organizations, not just in Ontario, but their sister organizations across the country, and really saying that we keep thinking that people are monolith. You're experiencing one type of barriers, but people are actually experiencing multiple barriers at the exact same time, and we need to find ways to share back their stories. That project in community became one of my area of research that I lead in the Access Lab at the University of Toronto that focuses on pandemics and public health emergencies, and it focuses on Black and racialized immigrants with disabilities. We've expanded the program to include first and second generation Black and racialized disabled communities to understand the barriers and challenges they experience during and beyond the pandemic, the cost of isolation, the cost of not having access to the education, health, and social services that they needed. And one of the things that this program of research really pushes us to really think about is that these systems are not broken. These systems have been designed this way to privilege some and to underserve many. And the community members that we work with are Black and racialized immigrants with disabilities and community organizations. I'm privileged to say that Ashay and I will be working together going forward, as well as many other community partners. One of the unique access of the Public Health and Pandemic Research Program that I lead focuses on working in community. So really listening to what our community partners, people with lived expertise are sharing with us about what they went through during the pandemic and what they continue to experience to this day. And how do we ensure that what happened does not happen again? Another program of research that I lead I'll focus only on two, and then I'll pass it on, focuses on caregivers with disabilities. I have to really honor my parents, especially my dad, because this came from, as a caregiver for a parent with multiple disabilities. Understanding the challenges that he experienced, not just during the pandemic, but throughout his whole life. And rarely do we think of people with disabilities as being caregivers, but they're community members. Many times they're caring for others while caring for themselves at the same time. And so throughout this talk, I'll have an opportunity to pull on the work that I do around pandemics and public health emergency, and the work that I do that focuses on disabled caregivers. And if I could leave with anything before I pass the mic is, I hope that you remember that none of us live, as Audrey says, single-storied lives. We have multiple identities, and many of us live at the intersection of multiple differences. Thank you.
Thanks very much. Thank you. Okay, thanks very much. Can you guys hear me with this lapel? Okay, maybe I'll just, there we go. Okay. Thanks very much. That was wonderful. Pass the mic.
All right. Am I on? Can you hear me?
Yes.
So thank you for that lovely and long bio. I have worn many hats in my lifetime, and as an alumni from the University of Toronto, and also as the inaugural Assistant Dean of Students International Community at the University of Toronto, Scarborough. Is there any Scarborough people here? Woohoo, Scarborough. It places me in a very interesting spot on this panel. So I'm coming to you as a Black disabled woman. I'm coming to you with that epistemology as truth and valid. I'm coming to you, as Collins would say, the outsider within, that knowledge that only those who have experienced it would know. I'm here to ask you to always think in your work and your studies and everything you do to remember the lived experience must always be central, valid, and elevated. So what have I done? How does my story shape into this conversation? I had a very rewarding career here at the University of Toronto. I was also at TMU, and I like to build. I like to see gaps, figure out why they're there, do that research, meet with people to figure out what are some of the solutions, and then build with those solutions in mind. That clearly involves research before, during, and after to see if there's learning or anything else involved with that change that we want. And the change we want in the Black disabled community is liberation. What we want is to be seen, valued, and in positions where we can lead research and live the lives that we feel we want to live. Ashay's mission is Black people thriving on a path they design. In that, you can hear, they design it. Their experiences, they get to choose. They're not supposed to be lumped into one category in monolithic environment. Oh, you're this or you're that. Many of you will look at me and you won't see any disability. I don't have my cane today. My joints aren't inflamed today. My memory seems to be okay so far. I don't have notes. And if you see a little bit twitchy, that's the neurodiversity talking. And I want you to welcome all of that in today's panel for me. I want you to understand that I masked my disabilities for 47 years. This is something many people in the Black, racialized, and Indigenous communities do, not just for survival, but also they can't have the double or the triple whammy. They can't have more layers of opportunity for discrimination and exclusion. They can't in their own communities because we've all been raised within the same systems of oppression. We've been raised in the same system that was not created for us. And that means is we all are mechanisms, work within the mechanisms of colonial power, meaning that anti-Black racism, gender-based violence, ableism, all of the isms are all stemming from the same problem, colonialism. And of course, you can see I work with it very much within the decolonizing framework. But what I'm saying this for is so you can understand something. Those systems are everyday practices. We know that Gramsci and Fanon and all of them have talked about these experiences, and you might have researched some of them. They're relevant to this topic today. I'm relevant to this topic today because at the time in my life where I could no longer mask my disabilities, I was denied accommodation. That denial, wrapped up with my post-traumatic stress as a survivor, changed my entire life. And that's what we don't understand. And then, as that life was changing, what else happened? The pandemic. So while I'm going through a process of understanding my disability. And we are, there's a paper coming that's Black Disability Confidence and the Black Disability Journey, Identity, that doesn't exist for Black people. But that's what we have to go through to be a part of the disability world, to prove everywhere we go that we have a health issue. Not believed in every setting where you ask. I do not present like a woman with post-traumatic stress or rheumatism or cognitive issues, but I have. But because Black people identify and engage differently when it comes to health issues, we are seen differently. And if we add on the inequities within healthcare when it comes to Black bodies and Indigenous bodies, we are not getting care in the first place. So when a pandemic or an emergency happens, we are left completely outside. And sometimes we're not even near any of the buildings of healthcare. That is my story, and we'll use that experience and my epistemologies to work through all your questions and our discussion. Thank you.
Thank you.
Thank you. Wow. It's hard to follow you always, Liza. Good evening, everyone. It's wonderful to be here with this extremely, extremely exceptional panelist and all of you here today. You know, my perspective on this topic comes from a couple of different vantage points. First, me being a registered nurse. I'm a registered nurse and was able to volunteer during the COVID-19 pandemic. Second is from the fact that I represented, and I also live in Brampton, which was one of the hot spots in Ontario when it came to the last pandemic. And third is from the point of view of as a policymaker, because I've had the privilege to serve in Canada's government in different portfolios, from being the Minister of Seniors to being the Minister for Diversity, Inclusion, Persons with Disabilities, and Minister of Health. And you know, those experiences truly reinforce what we've actually heard from both Chavon and Liza, is that when our systems are under pressure and when they're strained, who gets care and who actually gets access to that care, it affects people differently. And you know, we can talk about the structure barriers, and I know we're going to do a deep dive in really about age, about race, about socioeconomic status, whether it is a disability or where you live and what race you are. They truly do impact how people get care and who actually gets, to Lisa's point in the end, not even near a clinic or a hospital that you can think about. So I think, relatively now, gosh, someone reminded me, we were chatting earlier, it's been 6 years since the last pandemic, and gosh, for some of us it feels like yesterday, for some of us it feels like a lifetime ago. But thinking about the pandemic and just looking kind of relatively to the other jurisdictions, and I mean other jurisdictions outside of Canada, I think Canada did relatively well in terms of mortality, if you were to look at it, compared to other jurisdictions. I mean, just look the south border. But when you look at where it's shown the true light of the lived realities of some of the most vulnerables within our healthcare system, it was tragic. And we're gonna do a deep dive, I know, about some of those realities and inequities that exist within our system. But I think it's really important to have I'm so grateful to have these conversations with the panelists here today to really look at how can we build systems that can be sustainable, that are more equitable, that are more inclusive, so that we don't have to wait for the next pandemic to tell us, where those inequities are. Let's fix the system now. Because, I always say, if you want to make sure that we're ready for the next pandemic, make sure we're ready for the most vulnerable in our communities today. Yeah, but I mean, that is the narrative, and I think it's really important. If we can take care of the most vulnerables in our community today, we're going to be ready for anything and everything. So I'm really grateful for this conversation, and I'm looking forward to kind of diving into, I'll be quick, so I want to kind of dive into some of the discussion here today. Thank you.
Here we go. I think that's good. Thanks. Thanks to all of our panelists. I'm clearly not good with any mic. I'm really, really sort of moved and excited to have this conversation based on how you've opened, and all of you sort of mentioned a few things that I think are important to pick up on. The first was the obvious differences in care that we see during pandemic times and other times as well. And the other thing that I was really struck by was the idea of communities and community organizations and what role they play. And in fact, one of the questions that we've been asked is about how community groups can fill in gaps left by the healthcare system. So I will open the floor if anyone wants to start. Yes, it's how can community groups fill in the gaps left from the healthcare system? There's lived experience is the correct answer. So.
Some people know me in this audience. They know I see deep picture. Can you hear me?
No.
Okay. Anybody that knows me knows I'm straight, I'm authentic, and I will not bend in my purpose. So the first thing I have to say to that question is, it's not supposed to be all on us, who are the major underfunded organizations doing the work. So any politicians or anybody that's interested in policy, those people need to understand that it's great that community organizations are doing this work, and it has to be done by them. But you need to fund them. You need to make sure there's a capacity, long-term core funding, not program-based funding that ends. So it's really important that before I talk about the work that we do, that I make sure everybody clearly understands that it's underpaid, it's precarious, and it has a lot of Black, racialized, and Indigenous people, many with disabilities, many social support parents, many with low incomes doing all the work. Now, how can we help? We are helping because community wants to see their own community. Community needs trust. Community needs to understand they are not the only ones. I would never have told you I had a disability at 47, ever. I would never have told you I was a sexual violence survivor. It took time. And you want to know what brought me to it? The community of people in Shea. Being in a community of people that saw me, didn't judge me, and weren't expecting that Black woman trope really brought me where I wanted to be. Where we could be an organization that saw people. Where we could be that open door to say, come, we see you, we know you, and you have space here. And when you come and you have issues about accessing a doctor, because we know almost half of Black women do not have family doctors. We know doctors can refuse care. So my case is complex. So a lot of doctors don't want to deal with complex health issues. So there are so many things. But at Shea, we offer lots of programming. But the one at this example I think is relevant is we have a new program called FUI, which is the Financial Empowerment and Economic, I don't know if we said justice model. And what this is getting people their disability benefits and getting people financial coaching and support so they can be independent and manage their own lives. But guess what? the part of our work compared to all the other navigation programs is creating the community first. And the community and the network and the trust is where the community organizations become invaluable. Whereas a partnership like this panel right now, this is unbreakable between community, political, and a nurse, and a researcher who does community. When these kind of things come together, that's how communities' voices get elevated, and that's where people are. People are in the communities. Thank you.
Thank you. So I want to build on what Liza said, because I think this is so important, and I want to share some of the stories of the Black and racialized immigrants with disabilities we had an opportunity to connect with since 2022. The number one thing I want to say is that community has always filled the gap. They've always been filling the gap. It just became more evident with social media, and with us speaking back about having to fill the gaps while they are being defunded, being underfunded, and they are strained on multiple fronts. And what the folks we spoke to shared with us was that they went to community to receive information around the pandemic. They found that the public health messages that were being put out, it was not always accessible. It was most of the time communicated in English, not in plain language. If you use an assistive device like a screen reader, if you have a visual disability, or or you need a type of software where you need the text to be read, folks were not able to access that information. Everything was put online, but we didn't necessarily think about the diversity of people, of the diversity of needs that existed. So the folks that we spoke with said that the community is actually what supported them. We met a participant who met other people through the community. They formed a WhatsApp group, and when he was confused about whether or not he should be following the guidelines that were put forward by our government, he went to his WhatsApp group and he said, "Hey, I saw this flyer, what do I do?" And through that WhatsApp group that he met through a settlement organization, they were able to verify whether or not that information was legible, and they were able to share that back with him. So again, communities have always been doing this work. And what we have learned too is that communities became system navigators. They became these cultural brokers, a role that they were not paid for. So when we were looking at that question, I had the same feelings as Liza did. And I think we have to be really careful that we don't continue to download work to community, because we've done this with families too. We download work to families. We assume people have communities. We assume people have others that can care for them, because we exist, in this world of we are independent. We know we're not. We live in an interdependent, interconnected world. And when we start to understand that, and if public health can work in tandem with community from the bottom up, centering, like we said, the most underserved, the most under-resourced, we would actually be proactively responding to issues as opposed to continuing to be reactive and making things worse. We still don't know, the longitudinal impact of the pandemic, but we will know in a few years. We hear from community members how they are being impacted. So I'll close by just saying that I think it's important that public health and community partners, organizations, and people with lived expertise are working together to plan for the next emergencies, to look at the pandemic policies. And it makes me think again about who and what is essential. Who gets to determine what services are essential? And how do we continue to start from the bottom up?
Thank you. I just want to add to both what Liza and Chavon talked about, but I don't think we can ever underestimate the power of community organizations. I think we've all, within our own communities, I'm sure, have seen the power, particularly during the pandemic, how people relied on community organizations. There was no one else. When there is massive amount of information that is coming out every single day, where normal individuals wouldn't be able to get, you're changing rules every few hours. But to change that, to ensure that this is, whether it is a different language, whether it is making sure it's serving the needs of someone with disabilities, so that the individual can get access to the proper information. I was a member of parliament at that time, and we relied heavily, and thank God, and it was the work that the organizations have done and you're absolutely right, it needs to be long-term sustainable funding. When you talk about public health, when you talk about primary care, where you have 2.5 million Canadians that would have access to a primary care provider in Ontario. Think of the role that a community organization, when you talk about these primary care models, how important it is to have these community organizations to be integrated within that primary care. And I just want to give one example, particularly during the pandemic. I was helping run one of these vaccination clinics in Brampton. And you will remember, when vaccinations first arrived, it was hooray, yes, they're here, but then there was a lot of misinformation and disinformation within different communities, within different faith groups, and the reality is, like, many mixed group had, because of their historical challenges within the healthcare system, people had a lot of, for the right reason, concerned about, is this even right for me? And I will tell you, the way that we partner up with different organizations, I'll talk about one organization, Roots, I'm sure you've heard of them. They're very active in African, Caribbean, serving Black community members. The way that they brought in their entire community together, ensure that the people that were providing the care were Black nurses and doctors who were giving them the right information to be able to build that trust within the communities. I can tell you and there's people that told me I would have never gotten this vaccination. I've actually never gotten a vaccination, but I've only got it because this was led by my group, because I care about this, like I can trust this group. So I don't think we can ever underestimate the power of community organizations on the ground, different faith groups that showed up, because that is how, to Chavon's point, we're only a community with the people that are around us, and to ensure that we're building that trust with those individuals who are giving that information. So a huge component in making sure when it comes to not just emergencies, but primary care right now, they need to be integrated within our system to be able to provide that support to communities. And to your point, not download them to, you're not a doctor, you're not a nurse, you're like the third person that we may need you. No, you need to be part of that integrated healthcare system that I know we're all trying to achieve. But thank you.
Maybe I'll ask you a sort of question that you've touched on, but I think it would be great to hear you expand on it. It sounds like what you're saying is that there are inequities that are sort of long-standing, that are there clearly well before we hit emergency situations and well before we hit, for example, the COVID-19 pandemic. Did things shift or change in emergency times during the pandemic or in other instances that you can think of? Are there different dynamics that play out in those moments, or do you feel that it's a sort of continuation of what's already happening? Do you shift into other modes?
For me, yes. So first, accessing, like you said, a primary care provider who is supposed to be doing your continuity of care when you have a disability was not accessible at all. Going into these locations with sick people, like the clinics, for a compromised person, was not accessible. The wait time for doctors was not accessible. When they went and did the online virtual, it supported some of the needs, but that was very helpful for disabled people. The only thing it didn't do was allow for cultural exchanges or for the doctor to see you. Because when you have a disability, it's never really just one. And so I like that question, because the inequities are really clear within the Black community. The fear of the healthcare system and vaccinations and all these things is real, because it's the history of how Black people through the Americas have been treated, like guinea pigs. So when they hear of something, I'm going to give you a real experience. There was difficulty not just accessing medical care. To me, there was difficulty accessing all kinds of disability supports, physiotherapy, all these other things. But it was particularly difficult in a community that feared the vaccination to the point that they had the highest COVID rates and deaths, right? Is that right? So now imagine you're a Black disabled person who's immune compromised. Because of that fear, and now you have the inequities already. And now you have an emergency and COVID. That one trusted doctor or that specialist, I have like 5, you don't have access to. So what happened to Black people with disabilities, they were on their own. I begged, I pleaded within Black community spaces, please wear the mask. Please wear the mask. Please get the vaccination. Half my family didn't get the vaccination. They all got COVID. I didn't see my grandson for a year because that family decided not to vaccinate. That's what happens even within community. So when you have all these other problems and then this emergency comes in, it actually makes the vulnerable individual who needs the continuity of care more vulnerable, and of course in that mental health goes down, or my mental health got worse. My autoimmune problems took a flare up wildly. You know, I'm sure that's contributed to some of the cognitive decline. You know, all these things. And even in the community, when you have that intersection, sometimes the community doesn't understand that either. So we have so many health-related issues that when you intersect with public health and then you add on an emergency like COVID, we haven't dealt with those issues. So that means, to me, educating these cultural groups as well. And that's why I love the work. Because Roots did it, Tropicana did it, Black health organizations did everything they could. But there is still more education needed in these cultural groups before the next emergency. And I just wanted to make sure I said that.
Thank you. This is a really good question, and I appreciate that you started by reminding us that inequities are built into the social fabric of our society. They didn't just come up during the pandemic, they became exasperated during the pandemic. And what, as Liza's speaking, what you made me think about is this notion of a typical service user, a notion of a typical patient. Usually when we think of typical, we think of white. We think of middle class, able-bodied, right? Or temporarily able-bodied. We don't think about someone with communication differences. We don't think of someone that is a newcomer, someone that is unhoused, someone that is poor, that is also disabled. Again, this idea of a typical service user having, just one identity, one experience. And services have been designed that way. The folks that we spoke with in our pandemic studies spoke about, for some of them, when services moved online, they said they didn't have to deal with trying to find accessible transportation, because if they're trying to use Wheel-Trans, for example, in Toronto, they had to schedule it at a certain time and you have to wait. And if you miss your time, you're late for your appointment, and there's no guarantee that the physician is going to see you or you're going to make your rehab appointment. They also talked about the fatigue of traveling to different appointments. So for us, it was both. We heard about the benefits of services moving online, but for those that benefit from services moving online, they had access to the internet. They had some knowledge on how to navigate services online. They were confident communicating in English. And they had, this is really important, a relationship with the healthcare provider that they worked with. They had a relationship with the healthcare provider that they worked with. For the other folks that we spoke with, they talked about having to now being the person that coordinated care, that continuity of care that Liza spoke about was no longer there. And especially for those that were caring for other people, whether that's aging parents or young children or a community member, they're trying their best to survive during the pandemic while also trying to care for the other people that were in their community. They talked about how now that services that were online, the different healthcare providers didn't communicate with each other, so then they now had to do the job of the administrative staff that they would work with if they went in person, and had to say, okay, well, what do they know? What paperwork do they need? Had to make sure they had a stable internet connection. If they were doing physio online, for example, they had to consider whether or not the place that they were living in was safe, who was around as they were doing this, who could help them in setting up their computer, and that people didn't ask. Healthcare providers did not ask them, do you have the ability to access service online? So I know I'm pivoting a little bit, but I think it's important to talk about, like, with the rise of online care during the pandemic and the continuation of some care being offered online, it led to a lot more difficulties with people with body-mind differences that don't fit into this idea of what a typical service user is.
I mean, I'll just build on, I guess, I can't even speak right now, virtual care in general, right? I mean, we've seen, I think there are definitely some pros and cons to both virtual care. I think particularly during the pandemic, I can tell you, we've seen how quickly our systems can get overwhelmed. And I think it was important at that time to have those virtual appointments where people can get access. And I think also to ensure that there's room for people that really do need to see a doctor, they're able to go see the doctor. Because remember, there's restrictions. We told everyone, don't go out. So I think during the pandemic, virtual care also expanded to, whether it's seniors, living at homes, or whether it was individuals with chronic diseases or illnesses in their own homes. But I think, to Chavon's point, I think it's nuanced, because it's really important to look at, you talk about technology. Technology can also create more barriers, or does not remove every single barrier. And, to some patients who, may face culture or language barriers when navigating digital systems, many platforms, as we know, are not accessible. Just think of someone that may have a hearing impairment. How do they access, and are these designs made up to ensure that we're actually including those individuals in the care that they should be receiving? So I think while digital health can certainly help expand access, but I think it's important to ensure that the technologies that we're building around digital health are accessible, and ensuring that it has that equitable lens at the center of the care that people need. And it really needs to be about the patient. I will tell you, there are some folks that I know, they love virtual care, because they think that, I don't have to take a day off of work, and if you're able to get your prescription medication, and you're off you go, and it's easier, it's more accessible. But there are many, and many particularly, as Chavon talked about, within different cultural backgrounds, within individual disabilities, that we need to make sure we're making this accessible for them. So I think virtual care should be as a complementary care. It should not be a replacement care to the care that individuals are receiving.
Yeah, and I want to add to that, because as you were speaking, Kamal, I thought about the digital divide that we see that's happening, or that continues to happen right now. And I can share, based on the stories that we heard, folks talked about how if care is going to be offered online, make it hybrid or optional, because there still needs to be an opportunity to connect with someone in person, and think about that offloading that happens, that idea that a patient has to be the one that does all the coordination of care. We have to think about who that person is. Healthcare is about humans. These systems are humans, human-made systems. They're designed by us. We can redesign them to meet the needs of everyone.
Well, that's okay. Thank you very much. You touched on many things that had come in as questions for you, so I appreciate that. In the interest of opening to the floor, maybe I'll just ask you one final prefab question, if you will, and that is to reflect and consider, if you will, what you would say to people at Dalla Lana School of Public Health, our Master of Public Health students who are graduating and going into the world, or in the midst of their studies. What advice might you have? What do you think they should consider as they think about what to do with their lives, with their expertise, and any kind of words of wisdom you have for them?
I'm going to go first. Which one wants it? Come on, we'll fight first. I don't fight.
Liza, come on.
I'm spunky. The first thing I wanted to say, which I totally forgot, and I'm looking at Incam Obona in the audience, we also participated on a research project with Dr. Hilary Brown on sexual and reproductive health of women and gender diverse people with disabilities. And Ashay, and Incam is right here, was the lead of that research, specifically on Black people. And without taking up any more time, the paper, which isn't finished yet, is titled A Crisis in a Crisis. Yes. So it's the full loop of what has actually happened to women and gender diverse people for sexual and reproductive health. It is tragic. But I'm going to give you some advice. I've been given advice throughout my entire life, and sometimes I don't take it because I can be a stubborn woman, but somewhere down the road, it clicks in. So I'm hoping I'm going to give you something that today or later on, it might be there. And if it comes up later on in life, find me on LinkedIn, we can have a chat. So what you have to know is, and it was said by Dr., we're human. The systems are not human. The systems weren't set up for human beings. The systems are set up for procedures. So when you head off to your wonderful careers or you continue on as a researcher, remember that we're not static objects, that we have a full dynamic life and a full way that we experience it, quite differently than every one of you in here as well. Remember that if you're going to do this work, you also have to understand the inequities that existed before. Yes. Your work will be invalid if you have not identified that there were problems before. Because in your work, you have to identify and understand it. If you're only going to look through a framework that you feel comfortable with, that makes you feel ease, I challenge you. Some of the frameworks you've heard tonight, or some of the frameworks you'll see Ashay uses, go look them up. Take a leap. Take a dive into that uncomfortable place that you have never been. Follow somebody on Instagram or LinkedIn that does that work, the community work. Learn from within. So I wish, I'm not going to go on, but that is really what I wanted to say. I would really love to see you embrace that we are human beings and the systems are not human, and to keep that always in mind, because when emergencies kick in, systems elevate and the humanness of the services all goes away. Thank you.
Thank you. So much of what we have been trained is rooted in the biomedical model of disability, which is about curing, fixing, and rehabilitating people. And as Liza says, a lot of these inequities predate us and they continue to impact us to this day. Unless we deal with the issues of the past, they become the issue of the present, and they become the issues that we will face in the future. I truly believe that just like these systems were made, they were designed, they can be redesigned. The World Health Organization says social justice is a matter of life and death. It determines who lives and who dies, who thrives and who survives. social justice isn't just this thing that we say, this thing that we do, but it's something that we embody because we truly believe another way of living, another way of being, another way of centering our humanity, our collective humanity is possible. If there's any advice I could give you, is to be a co-conspirator. It's not a bad word, it's not a bad thing, and know that you can make a difference. If you feel uncomfortable, if you feel that there's so much I don't know, take the time to understand what you don't know. I'm not saying this to you from a place of blaming, but I'm saying it so that we name it, so we understand, how these systems have been designed and what can we do to ensure that that other world that we know is possible is happening now. And it goes back to what Kamal said. We shouldn't be waiting for another emergency to come for us to be having another conversation like this. This is our opportunity to create those changes that we know it's possible. So we need to mobilize. We need to start from that ground up and build together. It's possible. We've done it, we've done it in different ways, and we can do it together because it really is going to take each and every single one of us. And those of us that are the most underserved and the most under-resourced should not be the ones screaming so that people are listening to us. As an academic, I feel incredibly privileged for the people that share their stories. And I always say that people are not voiceless. They're not faceless. I'm not here to give voice or make space, but I am here to amplify what has always been said. And I think I'll end by saying maybe we need to do a better job of listening better. Thank you.
Thank you. Wow. I'm just inspired by this room, and congratulations to the present and the future of healthcare, because you guys are the future. You guys are the present, and we're going to be all relying on all of you. So remember these faces. But what I'll say is what I what both Liza and Chavon already alluded to is healthcare, it really is about people and communities. And if you ground your practices in knowing that you're actually treating people, you're treating communities. And I think ensuring that, what I kind of started off with, that if you can ensure that some of the most vulnerable in our community are supported, I will guarantee you will fix healthcare in Canada. And, I often think about, my own experience. I was really young when I got into politics, so I'll just give you, to the young people, a bit of advice, challenge, always challenge. If you see something is not right, say it. If you see something is not right, do something about it. Don't be a bystander, do something about it. And I know that you have quite remarkable professors and teachers in this room as well that are doing this remarkable work, but never shy away from doing the right thing and standing up for what is right, and that is making sure that some of the most vulnerable in our communities, if we can fix that right now, gosh, we don't have to worry about a pandemic because we're going to fix healthcare in Canada. So thank you.
Thank you so much to the three of you. Thank you very much. That was wonderful. I think that's a sentiment that I heard from all three, which is making sure that we take care of the most vulnerable, and that's the way to make sure that we're all taken care of. So it's my pleasure now to open the floor to questions from the audience. I think there will be someone coming around with a mic.
Hi, thank you so much. This was amazing hearing from all of you, all of your stories. It's been so great. My name's Caprice, and I'm a policy analyst at the justice organization, the John Howard Society of Ontario. And we do policy and research work, and it's grounded in people with lived and living experience. Currently, I have a portfolio of the transition of care from custody to the community. So within institutions, we know that majority of the people are Black, Indigenous. So within that, and then within the current overdose and drug toxicity crisis, how do you think we should ensure continuity of care during these transitions? Almost dropped my water bottle.
Hello, what was your name?
Caprice.
Pardon?
Caprice.
Caprice, we'll talk after. I'm going to start with the first. There is a Black Justice Strategy.
Yes, we are.
And if you hadn't noticed, it doesn't have disability in it. Let's start there. It doesn't have gender-based violence. So if we have a strategy and it doesn't address what you just said, we are already far behind. So how do we make sure that there's continuity of care for these individuals that have the rights like everybody else? And Ashay did put in a proposal specifically to address what you just said. And really what's happened is there is no continuity of care when it comes to health, and there is no continuity of care when it comes to accommodations. And there is no continuity of care when it comes to getting them their disability benefits, or getting them assessed, or getting them on their medication, or putting them on a treatment plan. So it becomes an entire circle, whereas they're leaving, they're out, or they're wherever they need to be, but they don't have any of what they need to stay healthy, to be accommodated, and to be successful. So when we think deeply about how we're going to support people in these vulnerable populations, coming out of environments that public health has a lot to say about, right? Isn't disease, COVID and all that, wasn't really addressed well within the prison system. They're coming out of that. Maybe they have long COVID, who knows? And yet there isn't right now in any of the strategies, let alone the Black Justice Strategy, a strategy on emergency or a public health. There is none. So to me, I always start at the beginning. Go and look at what strategies are there, what policies are there, and investigate those gaps. Do some consultation, could be a research project, either way, and then start to formulate through that lived experience what are the gaps are. That's what we need to do.
Thank you so much. We've started that, and we have a previous project on it. We're building on it. So we're seeing like a lot of gaps within the north. Like you have to wait 2 weeks after you get out to go into like care.
Yeah,
So
it's
there's
ridiculous.
There's a lot of like,
It's
gaps
so
that don't make
ridiculous
sense.
that there are benefits for people with disabilities that we should be able to apply for them and have them sit there. So when they come out, they have access to them. But of course, because of the law, they're not eligible to apply for them. But these are not things that come automatically. It takes sometimes 6 months or longer to go through the process. Why can't we start that process from incarceration?
Definitely. Thank you so much.
Thank you.
Oh, sorry.
Thank you. Is there someone with a mic? I think there's someone in the front, there's people in the back.
Hi, my name is Darlene Verlo. I live near here. I'm a multiple alumni. I have a major local project. And of course, it needs money, so that it's not all just people doing stuff without money. So in the federal budget last year, there was an announcement there was going to be an investment in community centers. So we have a project, we have a building, we have lots of community, and there is an initiative with the UHN about NORCs. Have you heard of NORCs? Natural Curing Retirement Communities. Yeah, so we're going to create one, and it's going to be the first horizontal NORC. We have a building that just happens to be on the subway system. Like, how do you like that? And this is the Bickford Center, which is the ESL Center. So we've got people, immigrants, learning English. We happen to have 2 gyms in there, a dead swimming pool, a huge theater, an auditorium. We've got all that stuff. We'll need some money, because every time we talk to the local counselor, she says there's no money. There's never any money. Got a building, Now, we also have no federal representative, right? Because Chrystia Freeland has, yeah, well, hopefully we will get, yeah, but meanwhile, like, how do you even talk to anybody? Like, you know, there was this announcement, like, the whole, we talk about, there's an opportunity for prevention here through community coming together, blended with UHN. How do we work with the feds?
That's a really good question, and just because I have a little bit of insight in what you're talking about, because I was the previous minister for seniors when I first heard about, what's it called?
NORC, Natural Occurring Retirement.
That's right, and it is remarkable. So one of the things, and just for the record, I'm not in government right now, so don't quote me on any of this, but what I'll tell you, the things that at the federal level that we were able to do. So in the last budget, there's $4 billion that the federal government has put forward for health infrastructure funding. And this really is about, because there's a huge need, as you know, also about, you know, health infrastructure, whether it is, you know, those, the housing projects that you're talking about or other different projects. It was announced in the last budget. So what it is, and I believe it's going through CMHC to be able to look at different projects. If I were you, I know you don't have a federal representative yet, but I think the by-election is April 13th, yeah, 13th. So hopefully you'll be able to chat with someone there or like a neighboring MP. But I'm also happy to chat with you offline and connect you with some folks if you.
Yeah, I'm just wondering, like, this is nice, like, to say, oh, you know, blah, 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 community centers.
Yeah.
Is there any vision, like, so I'm old, there was a vision in the past, you know, about participation and that, you know, coming together, rah, 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 work your buns off. We used to have that. All I hear is, oh, it's a line item in a budget. I've heard nothing of substance.
I might just ask that this go offline just so we can get to a few other questions, if
But I'm happy to chat with you offline.
Great, thanks. Sorry about that. There's someone standing at the back that's been waiting for a mic.
Hi, thank you very much to all the persons who are sharing their knowledge, their research, their experiences, and also thank you everyone here to listen to what we all just heard. So my concern is that we look at health in bits and pieces. Housing, that's not Minister of Health, is it? In employment, is not Minister of Health, is it? But it all impacts our health. Is it accessible? Does it give me enough money so I can survive and eat proper food? Right? So who gets scared when the systems are under strain? Are the people who have the most resources, the more supports, the people who can speak the official languages or that can speak at all. You know, it's important that we are aware that the public health is also for us. We have a Minister of Health and a Ministry of Mental Health. How do you do that? Like, you know, my mental health doesn't stay home when I'm here. I promise you my mind is here. So it is imperative that we hear that there's no one solution. In fact, I adhere to what Dr. Verna Yu, the former public health leader at Alberta, she said every ministry should be the Ministry of Health. So in this particular impact, the systems have been under strain since inception because they're all split up and they're all fighting with each other for the resources. And when the pandemic came here, you know, the myth of, oh, there's no money for that, it broke because immediately the government produced $2,000 for every person who could not go to work by no fault of their own, and these were non-disabled people, right? Meanwhile, people with disabilities were receiving almost half of it, $1,100 to be exact.
Could I just interrupt for a second?
Sure.
Do you have a question?
I do, and the question is,
sorry, we might have to just move
what
along.
would it take for somebody in the government, provincial or federal, to bring it all together. Like, would you agree, disagree? Is that an option or a solution to actually have one table, one conversation, not 15?
I mean, I can just touch on this a little bit. I think, first of all, thank you for your comments. I think you're absolutely right. Because the reality is, and when you talk about healthcare in Canada, right, like in general, Canada is massive. We have different provinces and the delivery is different. We have one, the Canada Health Act, but how it's actually, being delivered in different provinces is completely different. And yes, we have those federal, provincial, territorial tables where these discussions are happening. But the reality is also, and I will tell you, I'll share this with you, is what's happening, let's say in Alberta, BC is maybe not the same as what's happening in Ontario. But the impact of that for that same individual is the same. So I think it's really important, to your point, yes, absolutely, those conversations need to be happening. And yes, we need to center really the focus on the individual, rather than looking at all the problems. When you talked about health, housing, employment, the reality is that one person. So I think you're absolutely right in your comments, and I'm happy to kind of take that with me as well. But I think that's a really important comment. Thank you.
I have a memory problem, so I didn't bring any notes.
No, go ahead.
Sorry. It's very simple to me. These systems weren't set up to do any of the things we wanted to do, period. They weren't set up to support people. They weren't set up to be holistic. From the disability space, they're medical. They're charity. So there's nothing to do with that. They don't have the model because they weren't set up that way. So if we really want to change, we have to, throw the dynamite in and make that change. There is one last thing I want to say, which was particularly Canada has a commitment, whether we enjoy the United Nations or not. They have a commitment under the United Nations for the Convention of the Rights of People with Disabilities, where all of this is in there. And they have the new Accessible Canada Act, and all of this is in there. So they can go ahead, as we do in the Jamaican community, we give them a little rope, a little bit more rope, a little bit more rope. And for those sisters and brothers in here who know what I mean, what happens? Anybody want to say what happens? They hang themselves, or you yank the rope. Look what the Indigenous people had to do to get their rights. So if it means that we watch and we ask and we move and we move and we shift, and at the end of the day, we have everything lined up to what they're not doing, we have other bodies where we can push that change.
No, it's perfect. Thank you. Just a few things before we wrap up. And just to echo what Kamal and Liza said is that, and thank you, Janet, this is a great question, as the importance of all these systems are interconnected, right? And the way that they operate is in silos. So we need to understand how these systems are interconnected with each other so we can actually begin to respond to the needs of all people. I also want to add that we're aging, we're living longer. If we don't identify as being disabled right now, we will at some point in our life, if we live long enough, identify as being disabled. So we're not just designing for who we are now, we need to design systems that will benefit all of us in the long term. And this is a perfect opportunity to do that.
Great, thanks so much. Can I just see hands for anyone who still has questions so that we can get a sense? So what we might do is gather up a few of your questions and then ask you to respond en masse, because we've got about 7, for sure. We're going to get to him, and then we're also going to get to a few other people. So go ahead, and then we'll get to a few other people.
Thank you, Lisa. Appreciate it. So I've come to a few of these events at Dalla, Lana, and this is by far the most diverse crowd that I've seen at a Dalla Lana event. Thank you. And also the most diverse panel I've seen at a Dalla Lana event. And I think what I take from that is that the people who care about these issues are the people who are affected by them. But then when we look at who our leaders are, who represent us, they don't look like this room, because I've been in those rooms too. So we care, and we have the will to make change. but we don't have the power to make change because we're in these rooms, not the other rooms. So how do we get the folks, two questions really, how do we connect these rooms with those rooms? And how do we get those people to care? And I'm really concerned with not the what we have to do, but the how.
Excellent question. Thanks so much. Anyone else want to ask a couple? We'll get all of them accumulated. Anyone that you see with hands, maybe you can just sort of help us. And if you could keep your questions very brief so that we have time for the panelists to respond.
Hello. My question was about, I thought the community perspective and using your community or letting the community be involved in the response to things like the pandemic. I thought that was really interesting. But I kind of have two questions. I felt that in my community, the leaders that were stepping up at the time were nurses who worked in the hospital at that time, who had immediate access to information that we did not have access to, and they also had a really big network. They interact with people a lot of the time. My question was, how can those community leaders be supported and incentivized in the future for doing all of this work that they're not getting paid for, that they're not being supported, and they're kind of in this mid-role, they're this middle role that it's not like a position that was created for them, but they kind of put themselves there because there was need. So how can they be supported for a future situation like COVID-19? And my second part was, my second question was, how can we reconcile the misalignment between community initiatives and the overall response to the pandemic? Because I kind of felt that the overall response to the pandemic kind of stifled the community initiatives. How can people have access to their community if they can't even meet with their community? There's no official hubs in their community that they can go to for information. The community centers or anything public was closed. So those are kind of my two questions for the response going forward and how community factors into that.
Okay, sorry, we're going to have to cut off the questions so that the panelists have a few minutes to respond. So you want to give one more? Okay, let's do it. One more. That's okay, no.
Thank you so much. My question is really just around privatization of healthcare. So we're seeing a lot of efforts of privatization happening in Alberta and also Ontario, which is inevitably going to exacerbate health inequities. So what can we as individuals do to stop that from happening?
Thank you so much for all the information and stories. My question is...
Okay. Yeah, it sounds like we can go a little bit over, so why don't we at least try to address those questions. So there was a very good question about how to connect people who experience the issues, who care about the issues, with people who are in power, who are sort of running the show. There was a question about supporting community workers and community members who are doing the hard work. And there was a question about privatization of healthcare, the implications.
So perhaps I'll start and you guys can all jump in. But I really liked your question around how you can get in those rooms. And, I will tell you, I used to think like you a lot. I was 24 years old, a registered nurse. I used to work at St. Joe's Hospital, right here, not too far away from here, an oncology unit. And I saw the revolving door of patients coming in and out, they're not getting enough support, they're back, the revolving door we know about. And it was one of the primary reasons I got involved in my community. I got involved in politics. I got involved in making sure that I can see some of the things that I'm seeing in my community that are not working for people and to be in those rooms. So I will say get in those rooms. Don't think you can't get into those rooms. You can get into those rooms. And, get involved in your local communities, get involved in your local campaigns. I think your voices now, I always say, this population right now, you young leaders that are here today, you are one of the most educated, and some seniors, not seniors, but some adults, some adults. But I will say you are the most educated. The information that you have on your fingertips is enormous. Use that to your advantage and get involved, because what you think, you may not think you can get in those rooms, and all the things that you've been talking about, you can absolutely get into those rooms and implement that. And I think that I want to turn that to the last question first as well, because I will tell you, when I was in government, that worried me quite a lot, the privatization of healthcare that we are seeing in different provinces, and in fact, we're seeing some of it here in Ontario too. And I think it's so important to hold your politicians to account, the governments to account. I think it's so important for you to go and vote. For those, did you vote in the last election? Good girl. But I think it's really important when people say, what can I do? Get involved. Get involved in your local campaigns. Get involved. There's so many youth councils that different politicians and different members of parliament and provincial parliaments and even at the city level, get involved in those campaigns, because your voices, trust me, they need you. They need you, and they need to hear from you. And I think, just want to answer your questions around community organizations. I think it's such an important one, and it ties back to what I said. 2.5 million Ontarians that do not have access to a primary care provider. That number is insane. That's just here in Ontario. And unless we build that primary care team of support, that includes have doctors, nurse practitioners, increasing some of the scope of pharmacists and other members, nurse practitioners in the community, and making sure those community groups, those faith leaders are part of and integrated within the system, we can't reach the goal that we want to achieve. So I think they need to be empowered, they need to be part of the conversation, and in fact, they need to be integrated and strengthened within our primary care health models that we're seeing, at least across Ontario, but I hope that we can see more of that. Thanks.
Well, that was the answer right there. Thank you very much. 2 hours, my brain is doing its thing, and thank you for repeating the questions. I'm going to only speak to one. I'm going to speak to being in the room. I'm currently writing a book chapter and talking about not even being in the building. How do you do that? And people ask me, how do you just keep going? How I keep going is I know. I am absolutely knowing in my purpose. My grandmother, my mother, my aunties, my great-grandmother, those who enslaved, they had a purpose, and they kept going. And that kept going to move, to get into the next room and the next room. So if this door is not letting me in, we all know I'm not going to walk away from the door. I'm going to continue to kick at the door while I'm being allowed in other rooms. So I don't forget my fight, but sometimes look to other rooms. Look to allies you would never think they could ever be. And that's how we move forward as Shay. And then we get into some of these rooms with people kicking and screaming that we shouldn't be in the rooms. I actually went to the United Nations without disability organizations' approval. They were not impressed. I gave a speech that was organized through the Secretariat. They told me I had to have less than a minute, which was I wasn't going to do. They actually told me and told the students talking about Palestine, the law students, that it was inappropriate for their topic, even though the Secretariat. I'll listen to my story. They didn't want me there. They did everything not to tell me about it, to include me. When I was there, they hummed and hawed while I was in the gold room speaking the truth. They were on a WhatsApp talking terrible things about me that Human Watch showed me afterwards because they were concerned. The Human Rights Commission deputy commissioner was in the room, afterwards came and gave me her card. And 2 law professors, one from the University of Toronto who was the head of the school, law school, and another one from Columbia, grabbed me because I was so shaken and took care of me for the rest of my stay. They did not tell me where the meetings were. They didn't even talk to me in the hallway. And now look, where was I? I was in Geneva by myself. But guess what happened? Some of these people within these networks told me where the meetings were, gave me the information to prepare, had lunch with me, checked up on me in the hotel in the evening. Those is where you need to find yourself while you keep kicking down that door.
I'm going to try to answer with just one or a few statements and bringing all three questions together. And thank you for starting us all. All rooms should look somewhat like this. And if they don't, we need to ask why. And I think that's really, really important. We know this, the more diverse people, perspectives, ideas we have around the table, the more we are reflective of the society that we live in, and the more likely we are to be able to respond to the issues that are happening. And like I think you both talked about, it's also about coalition building, finding your people, right? And if you find people that are like you, that believe in what you do, you can push through those doors. I also just want to say that I'm really grateful to IHIP. IHIP has really supported my scholarship that focuses on Black and racialized immigrants with disabilities, and it actually sent me off. I was just sharing to Ted, it sent me off in meeting other amazing scholars, especially someone like me that is early career. It was challenging to meet very like-minded people, to meet people who would build up this work where I didn't have to change myself and what I do to fit into the institution. And then I was able to meet amazing students that are now part of this lab, the Access Lab that I lead, that get to coordinate this work, working with phenomenal community partners and people with lived expertise. And I think that goes back to finding your people, building a coalition, and having funders that believe in you, that will push, that you can also push back too and say, this is the work I want to do, this is how I'd like to do it, and these are the people that are missing from the room. So if we're in a room and we notice that the people that are there are not reflective of the people we need in the room, we need to use our voices. We need to use the power that we do have to push for that. Because I truly believe, like Liza said, it's nothing about us without us.
Great, thank you. Just a huge thanks to our panelists for such a great conversation, and thanks to all of you for listening and for participating. I think the panel was much richer for your questions. Just a reminder that the event will be posted to IHEP's website and YouTube page following the event, and we'll have closed captions. Please do stay in touch. You can follow IHEP and Dalla School of Public Health on their social channels on X, formerly Twitter, LinkedIn, Blue Sky, Facebook, and Instagram. I'm almost too old to be saying these things, but you know. Please do stay. There is a 30-minute sort of catering meet and greet mingle session after this. So do please stay around, and I hope that we will continue this diverse audience, and we'll see you in the future at other IHEP and Dalla events. Thanks so much.